Hello and welcome to our Public Health, Social Determinants of Health, Public Health Roundtable, How My Neighborhood Affects My Health. We are so excited that you have joined us. My name is Ramona Chapman. I am the Community Outreach Manager and Director of MOTEP at Gift of Life, Michigan, and we are excited that you have joined us here today for our first Public Health Roundtable. This particular roundtable has some phenomenal guests that are going to be participating. And I have the pleasure of introducing our moderator for today, Ms. Loretta Bush, who is the President and CEO of Authority Health. Ms. Bush has been a leader in health and human services field for over 35 years. She has demonstrated her commitment to access to health services for underserved populations, first as a public health officer for the city of Detroit and Wayne County, then as president and CEO of the Michigan Primary Care Association. She has served in key leadership roles overseeing the administration of primary care, behavioral health, and dental services, a school-based health center, community-based health promotion programs, and home visiting initiatives. As you can see, our moderator is quite accomplished. As a public health practitioner, she has extended beyond the United States borders and has served in Ethiopia, East Africa. Ms. Bush has received her bachelor's degree from the University of Michigan and her master's in health service administration from Central Michigan University. She is a proud member of the National Association of Health Service Executives and of Alpha Kappa Alpha Sorority Incorporated. So I am so excited to welcome my soror, Ms. Loretta Bush, as our moderator.
Well, thank you, and good afternoon to all of our viewers. Thank you, Ms. Ramona Chapman. Now, I'm going to have to do something a little bit different. I'm going to have to keep the next introduction shorter. I have 4 fabulous people to introduce to you. They are so extremely accomplished that if I tried to tell you everything that they would do, are doing, and have done in the past, it would take all afternoon and into the morning. So you can look them up later, though, if you want to know about their full biography. I'm going to start off with Dr. Jennifer Edwards. Dr. Edwards, wave your hand there. All right, Dr. Edwards is a leader in public health strategy and evaluation. She has 15 years of rich experience working in public health at the federal, national, and local level. She speaks on a variety of topics, including stress management, avoiding burnout, which we all need to hear more about, business, motherhood, and leadership. Welcome, Dr. Edwards. Next, I am introducing Dr. Mouhanad Hammami. Dr. Hammami is a senior health executive with expertise in strategy and operations. His background includes serving as the senior vice president for safety net transformation, community benefit, health, and well-being at Trinity Health. Prior to that, Dr. Hammami was the chief health officer and a director for the County of Wayne. Next, it's my pleasure to introduce Mr. Melvin McDonald. Mr. McDonald is an associate professor of social work in the Department of Social Work and Youth Services at Saginaw Valley State University. He also provides staff training in many areas, all centered around mental health. And then last but not least, it's my pleasure to introduce Dr. Renee Canady. She serves as the Chief Executive Officer for the Michigan Public Health Institute. Dr. Kennedy is definitely recognized as a national thought leader in the areas of health inequities, disparities, cultural competence, and social justice. Oh, and my light is going off. See, this is the beauty of being on live camera. I have a motion sensitive office, and if I don't move, the light goes off. Dr. Kennedy has been highly influential in broadening the discussion of health equity and social justice. I am also very pleased to say she is my soror, a member of Alpha Kappa Alpha Sorority Incorporated. Please join me virtually in welcoming our esteemed panel. We are going to jump right into the conversation today, and it's a very important one. As Ramona said, we are talking about how our neighborhoods influence our health. But with that, we want to give our listeners, our viewers, a foundation. But we've heard a lot about the social determinants of health, especially here lately. But that's not a conversation that's new to any of you here. But let's start off, Dr. Kennedy, if you will talk to us about what that term really means, the social determinants of health.
Sure. Thank you, Loretta. It's a joy to be with all of my new colleagues, some that I'm just meeting and some that I know. So I want to tell you a little context story to help our listeners think this through. If you're a clinician and you have two patients with the same diagnoses and maybe even the same prognoses, and you set up the same similar plans of care and you send them out of your office that day, in another month, they might come back and they've had completely different outcomes, and you're a little confounded from the clinical perspective. But what we realize is that when you send them out with that same prognosis, same diagnoses, that they're going probably to very, very different contexts to live their lives. And so when we talk about social determinants of health, the World Health Organization has defined it as where you live, work, play, and age. And some have added where you live, work, play, pray, and age. It's the context of our lives, our housing, our food access, our employment. All of those things impact our health both directly and also indirectly. So that's what we mean when we say social determinants of health.
Absolutely. What a great foundation you gave us, because you're right. We may all be look the same when we're in the office, but we many times go back into very different situations. So what are some of those, well, Dr. Kennedy really shared with us many of those social determinants of health that affects it. What about some of those political determinants? So we know that people go into different social settings, but also how does politics and the political determinants, how does that impact how people thrive in their life? I don't know if Dr. Kennedy, do you want to address that, or Dr. Edwards, Dr. Hammami?
Well, I can give another example, and then I'm happy to defer. It's actually a success that we've had in the state of Michigan. There was a law, a rule, a regulation that stated that if you had a felony history, that you were not eligible for SNAP benefits, nutrition benefits. So we have people that served their time, right? Did the crime, served their time, and were released, but were released to this burden of, they got decreased income because they've been incarcerated, and so could not take advantage of programs that were set up to provide nutrition to folk living in vulnerable circumstances. And so in Michigan, we're in the process of changing that law. We've gotten approval in our legislature to say, no, if you have that history of involvement with jails and prisons, that you would still maintain your eligibility to get this nutrition benefit. That's a political policy decision and example that we, for years, had the opportunity to put in place and didn't. So decision makers, philosophies, politics, which is really that tension around how do we distribute limited resources, who gets what and why. So that's an example of people making political decisions that impact our health.
If I may add to that, absolutely on the spot. I think when we talk about the social determinants and when we talk about them being the root cause of inequities and disparities, then one thing to recognize is that the social determinants are and disparities are because of the misdistribution of opportunity and misdistribution of resources. And this is where health becomes so politicized, because it is those that have power that put legislation or politics or even practices that are going to mismatch where the need is and the availability of resources. And this is where the political aspect of health becomes so evident. And as Renee mentioned, it's either legislation that is put without the impact of what it means to health, or whether it is zoning practices in a neighborhood, or whether it is the distribution of natural resources, or city planning where we decide where a bridge is going to be or what highway is going to split a community in half. All these are political in nature because it is, again, those that have power and those that do not have it that are going to be affected by what decision is being made.
Absolutely. You two have given some great examples. You know, today as I was driving in, I looked at a billboard and it said, vote like your life depends on it, right? And it really does. Dr. Kennedy, you have given one of the most egregious examples of what can happen that affects a person's life when past incarceration is keeping you from getting benefits to good nutrition. And Dr. Hammami, you have done the same. So, but it's not.
Can I just also throw out there that I want to make sure our listeners are clear that politics is not the same as partisanship.
That's right.
This does all have political implications, as Dr. Hammami has described. But we've now gotten in this uncomfortable place where we're allowing partisanship to get in the way of political decisions. So I just want to make sure that we're not talking about partisanship in this conversation.
That's exactly right. And we have to be informed people and look at the issues and not just the parties. Absolutely.
I appreciate your emphasis on voting. The things that we've heard now are absolutely governed by who we elect. And so we want to make sure that we are making informed votes at all levels of our systems, national as well as state and local elections. And I wanted to add a couple of additional examples where sometimes it can feel like we're just on a passenger, ride relating to our health, where things are so often out of our control if we're talking about the social determinants. And so depending on the state that you're in, I'm in Texas, and so it has its own political climate that's probably very different from Michigan, for example. Things like Medicaid expansion were being discussed, and access to health insurance by individuals that have lower income. And so those are decisions that were being discussed by our state legislature, and they had become state level political types of decisions. And then I would also offer an example that relates to all families, where we're talking about things like maternity leave, or now even parental leave, that is governed by federal policies. And we have the worst maternity leave policies in the world. And, that's a political determinant. The postnatal experiences of mothers and of families is governed by federal policies that really aren't keeping up with other places. So another example that I just wanted to share that underscores the need to vote informed and to choose policymakers that will support things that you see in your everyday life.
Absolutely. Couldn't have said it better. And you know what? We've been talking a lot in the realm of kind of physical health, but also we see the same thing as it relates to mental health issues. So, Mr. McDonald, what are some of the barriers multicultural communities experience when seeking care for mental health issues?
Yeah. So before we can even begin to talk about seeking, first we have to get past the stigma associated with seeking mental health services. A lot of the things that I hear, is, oh, I'm not crazy, so I don't need counseling or therapy. Counseling or therapy is for crazy people. Okay, so there's so many different stigmas associated with mental health that that it's hard for people to even get to the point of even seeking first. Another common saying that I hear, oh, if I begin to talk about the challenges that I'm experiencing, they're going to take my kids from me, those are many concerns as well. But particularly in the African American community, we tend to, we tend to be very faith-based people. And so there's also, I've definitely heard, so you don't have enough faith in God,
Yeah.
therefore here's these challenges that you have now, so you just need to encourage you need to up your faith in God, so there's all these different stigmas and sayings and things. But then again, we talk about the old saying, access to healthcare, right? Access to mental health services. There's a big thing right now. Do you even accept my insurance? So there's a lot of mental health providers who don't, who don't accept, the different array of insurances and things like that. There's transportation issues. Particularly in my agency, we saw that a lot of kids were not getting services due to many different factors. Again, transportation, parents just trying to balance so many different things. There's a stigma associated and things like that, where we created a program where we actually went out into the schools to provide mental health counseling for kids right in the school setting, But even those things, again, we still meet different challenges and different barriers when you're trying to implement these things for the population at hand. So, but those are the first couple of things that come to mind for me when we talk about the different barriers when it comes to seeking care for mental health issues.
So I know this is going to be kind of a broad question and you can't speak for every environment, but in general, you've mentioned some fairly deeply ingrained cultural issues like the faith based, and for some communities saying if I'm saying I'm having emotional problems or mental health problems, that means that I'm not trusting in God enough. I don't have enough faith. Or somehow it's demonic if it takes it to the extreme there, and just that whole pride of saying we're not weak people, we're strong-minded people. We pull ourselves up by our bootstraps. We don't go and complain to people about our problems, right? I see heads nodding. We all know that those are some of the things. So we know those things, but from what you've seen, is the mental health community prepared to, and we've only named a few, to deal with all of the cultural nuances that goes along with it, not just knowing how to treat and diagnose, but also being able to understand how much of that comes into play, even if a person has found their way to a mental health provider.
Absolutely, yeah. And I'm sorry, was there a question in there for me? I may have missed it.
There was. It says,
okay.
Is the community prepared? Have you seen that the community is becoming more and more prepared to address the multicultural issues?
Yeah. So from what I'm seeing, I can only speak from what I'm seeing. From what I'm seeing, I think we are becoming more accepting of having the conversation. We're more. I guess that's where I'm going with that. We're more accepting of having the conversation and looking at the fact that we're very complex people. First and foremost, and then secondly, yes, while the spiritual space that we hold, is very it's very important to to who we are as people, but at the same time, I'll put it this way: I've been doing a lot of looking at how again, particularly in the African American community, we will talk to it's less likely that we will go to a mental health professional, but we will talk to our pastors, we'll talk to the ministers, we'll talk to clergy, we'll even talk to barbers and beauticians in our community. We'll have those conversations in the barbershop, but when it comes down to, picking up the phone and calling a, mental health facility, or when it comes down to calling, a therapist or, a clinician, we're not as likely. We're not as likely to. But I do believe, and I'm, again, just speaking for like the church realm and things like that, I am hearing and seeing that we are more accepting to having that conversation and realizing that while in the church we can handle the matters of spiritual needs, we may not be equipped to handle the mental and behavioral health needs that people present with.
If I may add to that, it certainly is also another factor is, which brings us back to the politics of health, are the restrictions or the lack of available resources for mental health. So we know, for example, lack of providers. There is still that separation. Everybody that is on this call, and at least I know, Renee, you and I, we have been advocating and working towards the integration of physical and mental health since I had hair, probably. and we still find those barriers, and we still see that the first line of defense is either emergency rooms or jails for anyone who has a behavioral health issue. Until we establish these in the community with resources, with reimbursement legislation, with all the things that currently are not there, then as much as the community is prepared, it is not prepared well enough with crisis management, with those that are homeless, with those that are vulnerable, with those that have substance abuse issues. All those cannot be institutionalized, cannot be treated in emergency rooms or in prisons. These have to be programs within the community that are being embedded and treated as such.
Thank you. Renee?
Yeah, I'm curious about, actually, this is a question to my colleague, Mr. McDowell. I'm wondering about virtual, like we're doing online, physical fitness. Is that happening due to COVID in mental health? And maybe is that something you think that communities of color would hold on to?
Yes, it is happening in the mental health realm. When COVID-19 happened, mental health services, I can only speak for myself and the agencies and stuff that I work for, but while we saw a small dip, we're now seeing like this climb now, and a lot of the services that we are providing are telehealth. They are telehealth based. So yes, telehealth and virtual counseling, this can mitigate a lot of challenges, of barriers. But at the same time, does everyone have the know-how of how to use and operate it? Do everyone have the equipment to use and operate it? And if you do, and if you're using your cell phone, will your cell phone be on next month? Will it be on next week?
Yeah.
So those are the questions that we're trying to answer. So yes, we have a solution, or sort of a solution here with telehealth, but at the same time, here's more barriers, with even that solution.
So, Melvin, were you guys using a fair amount of telehealth previous to COVID, or was it like in physical health where it was a little bit, but you really got pushed into it because of COVID?
It was very minimal before COVID. Post COVID, now more than half of our practice is online with folks, and so that it's been a blessing and a curse. I don't know if I want to say it that way, but that's just the way it came out of my mouth just then. It's been a blessing and a curse. The blessing will definitely be, we've been able to reach not only just people in our community, but at the, if we're looking at Michigan, we're reaching people down here and up here, so we've been able to expand our territory, if you will. But at the same time, there's challenges to this. Some people don't want to have telehealth this way. They want to come sit in the office. They want to see my face, not just on a screen.
Right.
They want to feel the atmosphere of the office and things like that. So and again, there's just some people who just won't. This doesn't jive well with them.
Add to it the limitations that can happen, again, bringing us back to the context of equity and the social determinants. There has been some studies published on how many people have broadband internet versus dial internet. And it has shown that people in poverty, people of certain ethnic backgrounds, African Americans, are not, there are the digital deserts, and this is where they are. Some people have limited data plans till now on their phones, which, in addition to what you just mentioned, Melvin, that they might not know how, it's not a user-friendly technology, but even to conduct a whole session on your phone with limited data plan is going to be virtually impossible. So as much as COVID forced us to go into that we all wanted to embrace the technology, and telemedicine and telehealth is something that everybody else was doing it, so why not us? It is also now letting us isolate further those that are underprivileged and boxing them more. Even if we want to take it further and talk about online schooling, we know that again, now it's dooming some students to fail because they were not prepared. When you have 4 children in one house that have one computer and a lousy internet connection, you cannot by any means say, yes, online schooling is happening or it's functioning.
Yes. So is it fair to say, though, that the virtual environment is yet another tool in the toolbox, though it should not be exclusive for all of the reasons that you all have mentioned? Certainly, if we go back to the blessing and a curse, there is some benefit to being able to have that virtual environment for both physical health and mental health. Are you seeing that? Okay.
Yeah, absolutely. And just again, just one last point I would make in terms of virtual mental health services for kids, it's the hardest thing ever. At least for me. Other clinicians might have a total different take on it, but for me to work with kids virtually like this, yes, there are a lot of kids out there that are used to this online, even having headsets and talking and gaming with other people. They're used to that, right? But that was for the purpose of fun, right? That was for the purpose of entertainment. When we're counseling and having therapy with someone, the idea is not, the sole purpose isn't to have fun or for entertainment reasons. It's to help them to process, maybe some challenges or difficulties that they're going through, So with kids, it's been a much tighter pool than it has been for adults. Just wanted to add that piece.
For sure. So let's stay on the subject, but pivot just a little bit. And this is for anyone. Let's just talk about the medical clinical industry in general. It is known to have bias, so I'm not saying anything that's new to anyone on on the panel or listening. There's bias in medicine, so much so that even our governor here in Michigan instituted, anti-bias training and things like that. I want to hear your opinion on how we fix a system that was never really meant to serve everyone, a diverse population. How do we begin to fix that? Dr. Edwards, you want to start?
Sure. It's very challenging, and that's a large question to answer. But part of it has to involve having stewardship over hospitals and having an administration that is supportive of a culture of equity. If hospital leadership is interested in it, then they can start building a workforce that is interested in supporting the equity of patients. I actually was scheduled for a TEDx talk specifically on this topic and how women are being treated during their pregnancies, for example, and then it got canceled due to the pandemic. But this was part of the conversation where not only do patients need to be comfortable advocating for themselves and requesting that things be documented in their records if requested services are refused, for example, but that clinicians receive training and have a genuine value toward equity and be aware of any biases that they have. So not only addressing it from the side of administration, but also each individual provider integrating their own practices in their work every day as well. And then we as patients have that responsibility to ask the tough questions. Ask, how does our provider feel about certain things? Are they aware of the history of racial inequity in healthcare? Specifically ask it. And their answer is truly telling, and we can make a decision as patients about whether or not that's the provider for us. So it takes a lot of different partners to accomplish the goal of equity, particularly within healthcare. But over time, it certainly can be done. And I just want to be careful in saying that the whole system is not corrupt. The whole system is not mistreating patients, but it is absolutely a very real issue that needs to be addressed.
All right. Any other thoughts on that?
I think we have to address that, as Dr. Edwards mentioned, there is unconscious bias that we all fall into. That's a given, that's part of human nature. And this is where exposing that and bringing it from the subconscious to the conscious and making sure that we are aware of these things is part of the practice that is going to move us towards a more, a better, I guess, thing. The other thing is diversity and inclusion as not only something that we use as a buzzword, but as a practice. We have, especially in health systems, we have to resemble our patients. We have to look like the community doctor. And that should start by, again, in ensuring that opportunity is available. If we look at, let's say, African-American physicians versus the population of African-American patients, then that is absolutely lopsided. It is not real. So how do we invest in our communities? How do we invest in a system that is from pipeline to work, from school to work to whatever it is, how we are going to transform our health systems into a community that is diverse, that can understand those different cultures, that can also accommodate that with the training of unconscious bias and trying to de-assimilate some of those deeply inherited things that are inside us.
The one comment that I was going to, oh, I'm sorry.
No, go ahead, Melvin.
Okay, yeah, the one comment that I was going to make, and it just like it's ringing out in my head, don't talk about me without me, you know. And so, and when I say that, I'm saying, you know, there's many organizations and agencies and organizations that are making decisions for patients and clients who, however you call the people that you work with, they're making decisions, but how many of them are actually bringing those people to the table? You know, so when I say, you know, don't talk about me, you know, without me, you know, I think it's important that, you know, we bring some of those people to the table. But again, not only just have a representation, you know, just that face sitting at the table, but actually taking in, you know, what they're talking about and their experiences within that organization and hearing from them how they might need to be, you know, treated and addressed, and how, you know, and using that information to move forward the different processes that they have.
You know, I think one of the interesting and maybe even challenging things about implicit bias, unconscious bias, whatever we want to call it, is that it's just that. I mean, most providers are not starting the day thinking, who can I mess up today? Who can I treat badly today? You know, I think about research by Lisa Cooper, who is from Johns Hopkins, and she does work on what she calls racial concordance, when the race of the patient is different than the race of the provider. And did in one study an actual experiment saying to the patient and the doc, I'm going to video record and audio record your interaction. She gets consent. And even in that study, she found that the providers, when race was different, were less likely to have sort of social banter, that whole sort of bedside, setting the context, building the trust, were less likely to do that. Now, if you're a physician or a clinician or a therapist and you know you're being recorded, I'm assuming we're on our best behavior. So this idea that individual actions, then you have someone like me who's a sociologist, a medical sociologist, I come and lump all those behaviors together to look at a pattern. And so it's both at this personal, interpersonal level, but also what can systems do to help providers know that there's a tendency for these things to happen. How do we change them? How do we eliminate them? How do we set up a structure that helps not just patients succeed, but also providers succeed?
Right. And I couldn't agree with everything more. And Renee, that last comment, I know here at Authority Health, we have a residency program, and our residents, our doctors recognize that. And they ask, and we are providing all 3 years now, a curriculum on undoing racism, identifying bias. Because as you said, people don't come in saying, I'm going to treat people poorly today. And as people are more aware, I know our physicians who are, starting their career in the residency program, I think that is one of the strategies that have been mentioned here, that we have to start with the providers, and for us, we want to start with them as they start their career. We'll catch you later, but as you start your career and being able to do that for the 3 to 4 years they're in residency, we're hoping to see something special. The other thing, when we talk about racial concordance, so if we're going to have racial concordance, that means we have to get young people who get out of high school into undergrad, into medical school or doctoral program, so that they can then practice. And I think it was Mouhanad that started to talk about that. So we have to go upstream, right? Because if we want them to be able to come out of the pipeline and start working, we have to be able to get them in the pipeline. So there's probably a whole nother conversation that talks about how we go upstream and capture those young people before they get lost in the school system. Social justice. I've heard, we've kind of mentioned that a little bit, social justice, health equity. Renee, I'm going to go to you. And if you can, once again, give us a foundation on what do we mean when we say social justice, especially as it's applied to the healthcare system?
Mm-hmm. Yeah, well, it's kind of related to my comment. Are we creating a system, the conditions that allow people to be their best and their most healthy selves? How does the structure, the culture, the climate of our society and of our serving entities set up an opportunity to treat people equitably, not necessarily equally, right? And we all tend to be socialized that for something to be fair, it has to be the same. And from a justice lens, sometimes the most unfair thing you can do is to treat people the same, because their needs are different. So if I don't need that, but because you did it for the past 3 patients, then you actually are treating me unjustly because you're not identifying what my needs are. So it's giving ourselves permission to do that when we've been all sort of socialized that I have to treat everyone the same. Well, you have to treat everyone the same if what they need is the same. And when it's not, let's look at what their needs are and accommodate that. That is what justice and fairness really looks like in practice.
Excellent. Anyone else want to jump in on that conversation?
I want to talk a little about the intersection of our social justice challenges that are going on right now and how that can potentially be affecting our health. We kind of talked about it a little earlier, but we've really had a season of reaching an apex in terms of social justice and racial injustice and the stress that can come along with hearing those constant messages, living the life every day is real for many of us, where the fatigue and the sadness that we potentially felt is absolutely real. And so I don't want people to think that they're alone in that. There is a true connection between our emotions and our mental health that we spoke about earlier and our physical health. And so social justice is critical. And if we are truly being respectful of ourselves and are encouraging others to be respectful of us, then we want them to honor our experiences and honor our social needs.
Yeah.
We acknowledge that microaggressions are a thing. Microaggressions are real, and they do affect our workplace experiences on a regular basis. And that over time, that chronic stress over time can absolutely affect our health. And so there is truly an intersection there where, what we just heard from Dr. Canady in terms of that one-on-one experience. Then there's also the community level experience where we are collectively fighting for social justice right now, and of course in decades past, and that all of that can absolutely affect our health too.
Yeah. Dr. Edwards, just quickly, you used the term microaggressions. Give everyone kind of a foundation on what that means.
Okay, microaggressions are the small statements that can be made that are actually sending a large message undermining the person they're directed to. For example, if you're in a workplace setting with a lot of individuals who potentially don't look like you, and they try to undermine and discredit you in certain ways that maybe you can't necessarily put your finger on it, or they're just small statements that are showing they don't believe in your knowledge and in your capabilities. And sometimes they're done in front of large groups of people. Those are considered microaggressions. So they could be actions, they could be statements saying, oh, you're so articulate. Well, why wouldn't I be? Or,
that one before.
Yeah, or even having that larger conversation about the perceived angry Black woman, for example. Well, Black women aren't angry. Certain actions and certain words are automatically attributed to anger if associated often with a Black woman. And in the workplace, there are statements made that are microaggressions that relate to that and try to cultivate that negative image that is just really not true. So they can play out in a variety of ways, but it's different ways to discredit us, particularly when it's relating to gender or race.
Renee, it looks like you're wanting to jump in, and maybe Melvin.
I love exactly what Dr. Edwards just said. And I was just going to comment that it's, first of all, microaggressions are connected to the biases that we hold, right? So I always like the example of, for example, in an education setting, the teacher is passing back graded papers, and she hands a paper to a student of color who has gotten like an 85, and she says, "Good job." And she hands the paper to the white student who's gotten like a 92, and she says, "What happened?" And you could take those words and say, well, what's the problem? Like, she complimented the Black student, but it was about this subtle, like, this is pretty good for you.
For you, right.
I really have high hopes and expectations for you. And it's the microaggressions are so insidious that sometimes that's where, again, the mental health comes into impact, because you're sitting in a room going, did I imagine that? Did they mean it that way?
Right.
Am I overreacting? And in sociology, we call that effortful coping. In social psychology, where you're just kind of always on trying to figure out what, now there's this little saying out there where you go, what just happened? Did that just happen? But that has serious effects on our physiology, right? I'm not even going to get in Dr. Hammami's lane and start trying to talk about cortisol and the physiology of the kidneys and the adrenals and all those things that happen. But there's a physical consequence to those emotional, stressful microaggressions.
Absolutely.
Unfortunately, sometimes these are done with good intentions. Sometimes that teacher thinks that, oh, I'm just being, like extra open or extra friendly or whatever. I was in a panel several years ago, and this person was trying to be extra sensitive for different groups. And she said, oh, I have no problem with Arabs. In fact, I have a blog that is called My Best Friend is an Arab. And I told her, you know what? I take great offense to that, because do you have a blog that says my best friend is white? Or do you have a blog that says my best friend is American? Why are you going that extra mile just to single that for the group? So you're exactly right. When you are trying to take that extra step with good intentions, but you do not understand what the impact it's going to have on them.
Melvin, you've been smiling all throughout this. Is that, are you anxious to say something, or are you just saying, yep, all of this sounds familiar?
Yeah, it's a little bit of both, and it's like, you do understand that some people are just really just trying to give you a compliment, right? And that they're ignorant of what they're really saying, or how it's coming across, or how, but I commonly get, the whole articulate thing. I get that all the time. But as well as, people have to go out of their way sometimes to tell me how good of a father and involved that I am, and so, and that I'm present, and it just, and while, again, so I don't know. I digress. I just wanted to just throw that out there.
I think you're just kind of affirming that, yeah, it happens. It's out there. Dr. Edwards, you opened up a whole thing with that microaggression. Well, we're going to have to come back and maybe spend more time on that, and help people to understand that phenomena that Dr. Kennedy mentioned. Did that just happen? Am I overreacting, or was that really kind of inappropriate for them to say that to me? And how is that making me feel? And how that makes me feel day after day, week after week, month after month, when I keep going into those environments. So why is my head hurting all the time and my stomach flipping all the time? So that's something very much. I'm glad you brought it up, and we had some time to talk about it, because it definitely does affect the health and goes into the social determinants as well as the bias. So this roundtable is being hosted by the Gift of Life, MOTEP, and it's about organ, and the organization is about organ and tissue donation in minority communities. So we've been talking about a lot of things like social justice and bias and culture and social determinants of health. Who wants to kind of kick us off and talk about how all of those issues, or some of those issues, really impact organ and tissue donation in minority communities?
I don't mind starting it. I had the pleasure of participating in several of MOTEP's previous events, and it was fascinating when the first time I was asked to come and talk, where I did some research. It was fascinating to see the availability of donors from certain backgrounds or certain ethnic groups. And again, we see the exact disparities in the availability of donors and also the availability of resources. And I think it is multifaceted in terms of we want to investigate why this is happening. I think certainly there is the education and lack of awareness. There is this inherited skepticism of anything that we as minorities might experience in any medical setting that is asking us to participate in something that we do not understand. And then there is also the quality, if we want to call it that, the quality and access to healthcare that might not put us on a list that is going to prioritize those patients in a fashion that others might have. So it all depends on what is available for you as a patient and what the system is offering you. So it's a double sided where you have less people that are willing to be donors, and then you have also a system that is not as conducive for you if you are of a certain minority.
So what do you think with all of the things that are going on right now socially, all the social unrest, the increased, not only subtle, but, very overt things that are going on relative to people of color? How do you think that that's impacting a community's ability to trust something so important as organ and tissue donation? And we know some of the myths or the fears already associated with that in our communities, right? How do you think that what's going on right now impacts our community's ability to raise their hand and say, yep, I want to do this. I trust that it will be done right and at the right time and all of that. You know what I'm saying?
The toxic word, Loretta, is trust that you're using. I don't think we have a trust in the system right now. And I leave it, I know Dr. Edwards wanted to say something, but absolutely, trust is the first step that we need to establish.
Yeah. Dr. Edwards?
I wholeheartedly agree with that. And before I address a couple of things, I'll just take a step back and just say how important organ and tissue donation is. I first heard about it when I was about 8 years old, when my dad needed a bone marrow transplant. And I just felt this sense of helplessness, like I can't do this for him. As an 8-year-old, of course, they weren't going to let me. But ever since then, the issue has been super close to my heart. And so I appreciate the work that you all do. Right now, relating to even, things like clinical trials and all of that, there are all of these controversial conversations that relate to trust in our healthcare systems, because things like our organs are important to us, right? And so there has to be an ongoing demonstrated interest in our communities, so that trust is built over time, and having those one-on-one conversations with providers even. And then some of it, I feel, is that organ donation is somewhat viewed as unattainable. People don't even know necessarily where to start. They may not know all you have to do is check a box when you get your driver's license or when you get it renewed in many states. And so explaining the process behind it can also be helpful. And there was even some research done, and I think, of course, the ethics of this will need to be considered in terms of, do we make that box an opt-in box, or is it an opt-out box? So does someone getting their driver's license have to click an X to say, yes, I want to donate my organs, or is that X already clicked for you, and the person has to unclick it, which does give higher a higher participation rate, but we do want to think about, do people truly know what they've just agreed to?
Right.
And so I think a lot of times there's just lack of clarity in the process. And then, just relating to trust, the issues are just not too far behind us. If we talk about things relating to, the Tuskegee syphilis study, which I think is the most probably well-known, but then also the issues relating to Henrietta Lacks, for example, wasn't really that long ago. So how can we get past that? It will require an intentional effort in trust building. So I wholeheartedly agree.
And I'll just make just one comment, and it's really one sentence. But if I can't trust you, the systems and the powers that be, when I'm alive, what makes you think that I can trust you and what you say you're going to do when I'm no longer here? And I'll just say that.
Strong point. Dr. Kennedy?
I think we have to remember that trust is earned, not given. I love Melvin's comment earlier, if I can remember the quote, don't talk about me without me, right? That's based in trust. Can I trust you? You know, if I trusted you, it probably would be okay. Yep, I know you know my desires. Go ahead, talk about me. But we as a system, and the power rests in the system, we have to do the things that will reestablish and earn the trust of our patients. And we want to just sort of say, hey, trust me, I'm the doctor. And it does not work that way.
Does not work that way. Well, I tell you, we're talking about trust, and there is no conversation that I've had over the past now probably 10 months where I don't mention the word COVID, right? Especially in relationship to health. And we're talking about trust now, so I'm going to pivot for these last few minutes onto COVID. Trust and COVID, and saying that we're going to have a vaccine available soon. You know, I want to hear your thoughts about the vaccine in relationship to things like trust, in relationship to inequities, and just in relationship to just the larger topic of how you deal with ethnically and culturally diverse communities when you try to introduce something like a new vaccine, and particularly in this environment. So there's some hard questions in there. I see some head nodding, and I know you can do it. So let me open it up. I know you can do it.
So call me a hopeless romantic, but I believe that if we have a vaccine, I believe that once a vaccine is available, then it should be safe and it should be effective. I do not believe that the scientists that are working on vaccine trials at NIH and elsewhere are going to be politicized, regardless of what the political atmosphere is. So personally, I will trust that vaccine, and I will certainly be the first in line to take it. Unfortunately, this is not what's going to happen across the nation. I teach a class in public health at U of M, and I posed that question for my students. 99% said they will not take the vaccine. And these are public health students that know at least the importance of vaccines. And it brings us back to all the trust issue and what they're hearing on the news, what they're seeing on the news, and how it has been so used as a political pawn in affecting a certain, again, what Renee mentioned, parties. It's one party versus the other. If this vaccine was endorsed by this party, then half of the population are not going to take it, and vice versa, which is going to make that vaccine ineffective. We all know that if we want to achieve herd immunity with a vaccine, we need at least 70%. If not all the people are going to line up and take that vaccine, then it's not going to work, and we will not see COVID disappear. So this is where I think it has to become the trust issue has to be brought back and put in place.
Mouhanad, a follow-up question. That 90-some% of your students that are saying, no, I wouldn't take it, is that across the board with your white students as well as your ethnic students? Yeah.
Yeah, everybody. And some of them had good scientific background, and maybe they were trying to impress me to get the A. but many of them said, well, because we know that nobody would know about side effects until after a year. Maybe I'll take it after a year or something. So they were trying to justify it for that. But we all know it is because of all the hype that we're hearing from certain people in certain places.
Absolutely. I see Dr. Edwards, you've unmuted. Renee, you've unmuted. Melvin, you've unmuted. Let's go. Go ahead, Dr. Edwards, you go first.
Right. So this is such a complicated and challenging issue where I believe we all need to be educated, consumers of any potential vaccine. I tend to agree that scientists and researchers are going to appropriately engage in their protocols. Where I do believe there can potentially be pressures will be in later phases of the trial. So clinical trials have phases where later phases of the trial are testing the effectiveness and the side effects of the vaccine and observing those, where an effective trial does that over time. And so we have to think about, in this very unique circumstance, do we compromise that time element to get a vaccine out quickly or not? And so I think that's where the differing opinions might exist in terms of whether or not someone does take the vaccine, because the sooner it comes out, it certainly will not have been tested on hundreds and thousands of people before it's released. And so I think we all need to be educated in terms of whether or not we do it.
So let me just ask this a follow-up question to that, kind of a question, kind of a statement. I think we saw something similar with HIV treatment, right? Things came out really quick. The benefits to those taking it were so robust that clinical trials stopped and things went right into production. But then what we saw was an extreme disparity among racial and ethnic minorities who still were last to take it and were still dying from HIV, even though these treatments were already proven to be effective. So I just want to throw that out there. And I really would like to hear some of your thoughts around that. If we start to see that, how do, we as public health and mental health professionals help our friends, our colleagues, our patients to not sit on the sidelines too long if this indeed is something that we should be lining up to take, even if we don't necessarily totally trust the politics or who's saying it's okay.
I was pausing to see if Dr. Edwards wanted to continue to comment on that. Okay. So I think about in that context, absolutely right, Loretta, what you're describing. And these are all patterns that we see replicated across a variety of measures of morbidity and mortality. It doesn't really matter what the condition is. We see these same underlying concerns. And so I think about like the health, some health behavior models that we have. And in one of them, they talk about early adopters. And there is always, in any new phenomenon, going to be those that are right up front, like, yeah, I'll try it. I don't have any concerns because of a broad range of reasons. And so I think in this particular context where the tone is so contentious and the context of a vaccine coming out in the midst of social unrest, as Dr. Edwards mentioned earlier in our conversations, there are a lot of social things working against us in getting people to adapt. And so those who are the early adopters, we've got to really talk about their experiences and bring a lens of transparency to all the public. And then just as with donors, organ donors among Black communities, there are specific efforts to target African-American donors for bone marrow or for organs. We're going to have to do something specifically to target communities of color, particularly given the unrest of this moment and the history of lacking trust. And so I believe that I was asked this question once in a community panel, and they said, well, Dr. Canady, are you planning on getting the vaccine? And, there's a little pause because I'm a human, I'm a person, I'm a Black person living in this society, having experienced a lot of things. But I have to trust the profession that I've invested 30 plus years of my life to. And so, yes, I will be one of those early adopters, trusting the science, trusting folk that are neutral to the politics and the partisanship. They are scientists doing what's best. And I think we see that because currently we see 2 studies, trials that have been pulled, right? Because we can trust the scientists and we can trust the science.
Yeah, and I do think that that's what it's going to take. Trusted folks from the community like you, Dr. Canady, you, Dr. Hammami, who have both said, yep, I'm going to be a early adopter. I won't ask the rest of us to identify unless you want to. But, you know, that's what it's going to take. And that's the strategy that we've used for other things as well. It's not just the message. It is indeed the messenger. So it's going to be some work there. You know, I want to switch now to a topic that I know is dear to myself and to Renee and probably others. And that's talking about trauma-informed care and how that all fits in, right? Because you know, part of what we've been talking about is, you know, our communities have been traumatized, right? Things have been done to us, which is a part of trauma-informed care, right? You stop asking people what's wrong with you and you start asking them what happened to you. And as a community, African-American community, Hispanic community, Native community, Arab community, you know, the question of what happened to you is a real one. We come with trauma. So I just want to open up that conversation, again, in light of the things that we've been talking about, but certainly now around how do we get people to do certain things like preventative care, taking of vaccines, trusting that when the time comes for them to donate organs, that would be done respectfully and after they are indeed have passed away, if it's a vital organ. You know what I'm talking about there, right? So all of the trust things, but we're talking about communities that have been traumatized. Things have been done to the communities. So I just want to open that up for conversation, trauma-informed care and how it fits in to what we've been talking about today.
I'll just say, you know, trauma-informed care is so important in terms of mental health. I mean, you know, trauma-informed care, it recognizes the presence of trauma symptoms and acknowledges the role that trauma may play in the individual's life. You know, so if I'm working in a mental health facility and you know, and I have clients who are just not showing up, or maybe they came, or maybe we gave them some homework or things like that, and they're not doing it. You know, some people will just yell out and say, "Oh, they're not compliant." So you know, we're going to write them off. You know, they're not compliant. They're not serious. But what other work are we willing to do to start asking the questions? Well, why aren't they showing up? You know, why aren't they doing the homework? You know, what else could we be missing? And so, you know, we're trauma-informed care, you know, again, it would prompt you to ask those additional questions, to be more curious as to why versus just dismissing and saying, oh, they're not compliant, you know. So it's huge in the realm of mental health that we understand trauma, that we understand that trauma has an impact on people's functioning and the level of their functioning. So, you know, so that's just my comment right off the top.
Absolutely. Who else wants to speak to that? Thank you, Melvin.
Well, we certainly tie trauma with a landmark study on the ACEs study, adverse childhood events. And so we now understand from the science and the research that these traumatic events that happen early in life continue to have consequences throughout our adulthood in, again, physiological outcomes. This is research that came out of the Centers for Disease Control. And so how do we mediate the consequences? I was asked on one panel that if we knew COVID was going to affect communities of color worse, which we could have very well expected, right? And what did we do to prevent that? And I mean, I was just, you know, sort of stopped right in my sentence. So we know that there are things that are predictable and have to begin to both at the upstream level try to prevent those root causes. Dr. Hammami used that phrase earlier, instead of waiting until we get midstream or downstream and start treating those things. And so this increasing conversation around trauma-informed care and adverse childhood events is positioning us to do that, to think about the causes of the causes of the causes, not just the outcomes.
Right. I'm going to follow up on that for a minute. I know Dr. Edwards and Mr. McDowell may want to speak to this as well. But Renee, I want to follow up on something that you just said, that folks said, if you had known, what would have been done differently? And I want to go back downstream for a minute, because in many communities, one of the things was, well, messaging could have been a lot different. It could have been more in line with the way minority communities live. And I'm not, talking about, non-minorities trying to speak a certain language or anything like that. I'm not talking about that, but just understanding the way communities live. So when you throw out a term like, okay, y'all start doing social distancing, what does that mean? And then much later on, talking about the basketball court, talking about the line dancing that happens in Black communities. When you throw out a message like social distance and not really understanding the context that you gave us, Dr. Kennedy, talking about the way people live, play, worship. So just kind of responding to that, it seems like to me that goes back to how you opened up. If folks really take the time to understand how communities live, play, worship, then instead of social distance, it would have been understanding the way people live their life. Not that other populations don't do those things, but much later we started talking specifically about the things that probably led to not to discount the upstream of going into a pandemic not as healthy. We absolutely true. That's why I said, but let's go downstream for a while. So your reaction to that, and your thoughts about how we do better, because it seems like the health community keeps playing the same thing over and over again, right? The message is like, later on, that message isn't resonating with the people who are hardest hit. So now let's do it after we see that there's a disparity, instead of upfront saying we've got to understand how multicultural people live, work, play.
I love everything that you just said, Loretta. I think absolutely that, for example, when the colleges shut down and we sent students home, well, communities of color, minority communities, are more likely to be multi-generational homes, right? So we're going to go home and grandma's going to be living there, and my 5 siblings going to be living there, and mom and daddy are there, and now I'm there, and my bedroom already that I shared with 2 of my siblings has already been converted to whatever room for grandma. And so it's what seems like a simple recommendation, go home and social distance, in application is not at all the same, exactly because of what you've described. People live their lives very differently. We're less likely, minority communities, less likely because of the impact of poverty, to have 5-bedroom homes where it's like no big deal, like I'm in my room now, or you're in the den. So I think that we do have to begin with the end in mind. And I will say that I really believe that Michigan did a fine job of anticipating that. Early on, our governor was informed by our chief medical executive, Dr. Renee Canady, and about these disparities that they're anticipating. And so standing up a task force that would look at the particular disparities in COVID was quite candidly brilliant and has had significant impact on, yes, we saw those numbers get out of the block before us, but now we begin to do things downstream to eliminate those disparities. And our hope as a task force is that some of the lessons we learned dealing with those downstream outcomes will help us prepare for the next epidemic or other chronic situations like infant mortality and heart disease. Well, if we did it for COVID, what can we now do for these other conditions? So for people to sit back and just say, well, it is the way it is, and people are poor and some people get it and some people don't, is absolutely not the case. And we have evidence of that now in Michigan.
Right.
You did mention, Loretta, something that is very important is the messaging and how messaging should be tailored to the population that we want to serve. In one example, in my previous role at Trinity, as you know, we had several communities under the health system, but we noticed that in Hartford, Connecticut, which is 90% African Americans, low socioeconomic status, we are witnessing a high rate of people dying from chronic diseases, specifically cardiovascular diseases and heart attacks and stuff like that. And they are not seeking help for that or coming to the ER or something. And there was a very well-intended ad by the ad council that says, whether you have COVID or not, stay home. And as much as that message is very true and very proper, this is translated that I should not do anything. I should stay home. If I am dying, I will not go anywhere and I will not see a doctor.
Right.
And this is where the message is something that has to be tailored to people as they would take it and they would understand.
What an excellent example. You are absolutely right, Dr. Hammami, because there's now a lot of talk about how, staying home or, quarantining really protected people for COVID, but it sent them into some very dire health situations as it related to such things like control of diabetes and cardiovascular disease and all of that. Definitely well seen and well put. We have to be careful about the messages that we put out. Mr. McDowell, Dr. Edwards, you want to jump into this conversation?
Well, I wanted to add a maternal health perspective because it touches on a few things that have come up where we're talking about moms that are pregnant now during a pandemic. So they're having very different birth experiences. At one point, there was a controversy about whether or not even a partner could be allowed in the room during the birth. And the intersection of that with a mother's right to the birth that she intended. And so as part of that discussion, I would like to connect that to what you mentioned about messaging and saying that support is so critical throughout the birth experience and the maternal health experience, where things, if we're talking about on the ground, what can we change now or what can we advocate for now? A lot of times support by way of doulas and midwives is not as often spoken about in our communities, when really way back when that was how birthing was done. And so if we can start having conversations about the healthcare system involving also doulas and midwives and making sure that insurance covers those types of services as well, I think that's an important component to the maternal health piece of this, and also navigating the pandemic and making sure that moms have the support they need and that families have the support they need.
Yeah, absolutely important. From a public health perspective, we know that the health of a community is judged by, how we are, the health of the children, women, and our elders. So excellent point. Mr. McDowell, I want you to just kind of share with us what you and your colleagues may be seeing in light of COVID in terms of the mental health. Again, us sheltering in place and going home may have protected us from COVID, But now we haven't been able to see grandma. We haven't been able to be there for the birth of children. We haven't been able to appropriately bury our dead and, say goodbye. We just haven't been able to see our friends and hug and love on them and kiss on them and everything. What are you seeing out there? And what can we be doing? What can our listeners be doing?
Yeah, so everything you just described are common conversations that we're having due to COVID. The staying at home, but also, not being able to attend those important functions, so the birth of a child, the funerals that has happened since COVID, and, people not being able to, partake or, participate in, has left a lot of people, extremely depressed. We're seeing high levels of depression. We're seeing high levels of anxiety, just due to COVID and the contact, just even trying to get back out into society and going to stores and things like that, just so much anxiety we're seeing. But one of the major things that I am starting to see even more now is those that typically help now need the help themselves. So helping the helpers. So I'm talking about frontline workers. I'm talking about parishioners who, clergy who are typically the backbone of a community, have now this flood of people who are reaching out to them. And now the clergy are now reaching out to us saying, hey, they're reaching out to us, but they don't know that I'm secretly going through this myself, And so, now I need for you to help me while I'm helping them, So there's that conundrum now, where so many more people are, again, experiencing this depression and anxiety and things like that, and just not knowing where to turn. I'm sorry, lost my train of thought that quick. So that's one of the main things, that we're really starting to see, where we stand right now. But I think the other thing too is, while I'm having clients come in and they're talking to me about their COVID experience, guess what? I'm having a COVID experience as well. So it's not often that as a mental health practitioner, that the person who's sitting in front of me who are experiencing something, that I'm experiencing the same thing at the exact same time. And again, even though I use the word same thing, we know that, that we all perceive things differently, but at the same time, it's like, we're all in this together now, but yet even me as a therapist, I'm helping to talk you through your challenges, so even just trying to mentally process and deal with that is a thing as well, for us, for the mental health community.
Yes.
So that's my initial thought after that question.
Yeah. So, how about some of the tips that we've been hearing? How do you feel about, we've been told if you're working from home, make sure you open up the blinds every day. Make sure that you get up and put on real clothes. Those first couple of weeks, it might have been cool staying in those sweatpants all day.
Right.
But you know what? You need to get up on something that has a zipper and a button.
Yeah, I was joking with my friends, and I would say, like, you didn't want to see my COVID hair, my COVID hair, so, or my COVID beard and things, because, even I, again, it was just like, okay, I'm at home, so I'm going to be at home, so, even jumping on Zoom sessions with some clients, I'm a little scruffy, like, oh, I might need to take care of that, but in terms of, what you're talking about, opening up the blinds, putting on clothes, absolutely. These are the things that we absolutely need to continue, to do, going outside for walks and things like that, as again, we didn't, it's not desirable to see your family members on a screen, but still making sure that you are contacting those family members and, reaching out or on, contacting people over the phone, but also maintaining good sleep hygiene, also maintaining, good eating habits as much as you possibly can. Again, we talk, there's this whole thing about food deserts and, not having access to good, healthy food and things like that, and I'm sure that's for another conversation, but all of this stuff is still in play as well.
Absolutely. And then I'm sure just quickly, also watching our consumption of alcohol and other drugs, right? There was definitely an alcohol shortage there for a minute. There was definitely a tequila shortage, and I'm not going to tell you how I knew that, right? But in all seriousness, we want to watch those things that make us feel good, supposedly during this time, right? We are getting down to our last 3-4 minutes, so I want to make sure that we have covered the things that you believe to be important. I have enjoyed this conversation with the four of you. We've gone all around. We've hit on a lot of important issues. You guys have the last word. What do you want to say? Oh, that means we've said it all. Come on now, Dr. Kennedy. Looks like you want to say something, and then the rest of you get ready for your last, your one-liner.
Well, I'll just throw out that oftentimes as we think about the context of people's health, that if you're in a power position, or you might see a social engagement as an incident, but for many people living in vulnerable circumstances, it is a context. Like, it's one more time that this happened to me, whether it's the microaggressions or the being blown off by your provider, as opposed to, wow, that was terrible that happened to that person on that day. And so as we begin to reconcile that we all have very different lived experiences, and that the context of our lives does affect our health, then I think we will all be healthier together. Issues of racism and bias aren't just bad for the person who experienced it, it's bad for all of us. And so I'm grateful for the opportunity to share a little bit in this regard with our participants.
Thank you, Dr. Kennedy. Dr. Edwards, you got something for us? And then Dr. Hammami, and then we're going to finish off with Mr. McDowell.
I just want to thank you for having me here today, and encourage everyone to support the mission of organ and tissue donation. Illness and medical conditions do not stop because of COVID. So all of that support is needed, and continue educating and advocating and speaking up, and definitely get out and vote. So thank you for having me.
Thank you, Dr. Edwards. Dr. Hammami.
Absolutely. I echo that. One thing that I wanted to say, again, my romantic side is coming up, and we as humans have gone through a lot. This is not the first time we are challenged, and we always persevered because we're resilient, because we believe in ourselves, and we believe in humanity after all. And the only way to pull through it is to come together, put our heads together and our hearts, and believe in each other, and we will come out of this okay.
Wow. Thank you, Dr. Hammami. All right. We need another hour or so to talk about resilience, one of my favorite topics. Yes. And Mr. McDowell, finish us off. Take us home. You got to unmute, though, to do that. That's all right.
All right. There we go. All right. So just, my last comment is that we are all human, having a human experience. Okay. It doesn't matter who we are. We all need to assure that our mental health is taken care of. So take the time to check in on your mental health. Again, we will see a cardiologist if we're having heart problems. We'll see a podiatrist if we're having, a problem with our feet. We'll see, all these other people. But please see someone professionally, on a professional level, if you are having mental health, mental or behavioral health challenges.
All right. I want to thank all of our guests on this roundtable of social determinants of health, how my neighborhood determines my health. I'm not sure if our host, Ms. Ramona Chapman, who heads up the Gift of Life MOTEP, is going to join us again, or if it's my job to just say thank you for joining us, and we'll see you next time. Go take care of yourself and be good to each other. Bye-bye. Thanks, panelists. I enjoyed you.